Good afternoon, everyone. My name is Dr. Anthony Yi. I'm a respiratory specialist here at Changi General Hospital, and it's my pleasure to have all of you here today to join us at the CGH Clearing the Air on Asthma webinar forum. Before we begin, just a gentle reminder of our house rules. If you have any questions for our speakers during the session, please type them in the question and answer function below, and our speakers will answer some of your questions during the live Q&A session. As this webinar will be recorded, I'd like to remind you not to review any personal or confidential information. If you do encounter any technical issues, please email us at public_forum@cgh.com.sg. In today's webinar program, our speakers will share on asthma, suitable exercises that you can do to control asthma and the effects of smoking on asthma, as well as how to effectively quit smoking for a healthier you. So I'd like to start by welcoming our first speaker, Adjunct Assistant Professor Tunn. Dr. Tay is a senior consultant with the Department of Respiratory and Critical Care Medicine at CGH. She obtained her specialist accreditation in respiratory medicine and critical care in 2013 and 2015, respectively. She has been awarded the Health Manpower Development Plan Scholarship in 2015 and completed a one-year fellowship with the Allergy, Asthma and Immunology Department at Alfred Hospital, Melbourne, Australia. Dr. Tay's clinical interest is in asthma, and she heads our difficult asthma clinic here in CGH. She's also very active in asthma research and has published numerous peer-reviewed journals. So today, Dr. Tay will be sharing with us on the common misconceptions about asthma and how one can live well with asthma. Dr. Tay, please, over to you.
Thank you, Anthony. All right, thanks, Anthony, for the kind introduction, and welcome everybody to today's webinar. I have take great pleasure in doing the first talk for today, and I shall kickstart by clarifying some common myths and misconceptions about asthma. So before I dive straight into the myths, I'd like to provide a little bit of background about asthma. So asthma is a common chronic disease that affects airways in the lungs. Airway inflammation is one of the main mechanisms causing airway narrowing in asthma, and patients with asthma have inflamed and narrow airways, making breathing difficult. Apologies, let me just show my slides again. Right, so if you can see in the diagram at the bottom, our airways are made up of smooth muscles, which is this outer layer here, as well as an inner lining, this inner layer here. So in patients with asthma, what happens is that their smooth muscles are constricted and they have swelling and inflammation going on in the inner lining. And when they have an asthma exacerbations, their smooth muscles are even more constricted and they have even more swelling in the inner lining, causing the airways to become very narrow and difficulty in breathing. So what are the common triggers in asthma? There are many, and some of these include viral infections such as colds and flu, allergens such as dust mites, which you can find in our bedroom pillows, carpets, curtains, animal fur, irritants such as cigarette smoke, haze, fumes. For some patients, exercise may be a trigger, and for certain patients, stress and strong emotions as well. So asthma is one of the commonest chronic lung conditions worldwide and in Singapore, and an estimated 300 million people in the world have asthma. In Singapore, asthma affects about 20% of children and about 5% of adults. So it's common, and you may actually know someone around you who have asthma, or you yourself may have asthma. So with the next few slides, I would like to just clear some doubts about asthma, and I hope you find the information useful. The first myth I'm going to try to debunk would be some patients may say, if I'm not wheezing, it isn't asthma. This is not quite true. Wheezing is just one of the symptoms of asthma, and wheezing, it's basically a high-pitched sound from the chest when a patient is breathing. But other common symptoms of asthma include shortness of breath, tightness of the chest, as well as a cough. So not all patients may experience all the symptoms above. They may just have a few of the symptoms or even just one of the symptoms. And the minority of patients may actually just present with mainly a dry cough. And this is what we call a cough variant asthma. So the fact is that not all patients with asthma have wheezing. Second myth, asthma only develops in childhood. And again, this is not true. Adults may develop asthma even if they have never had asthma as a child. In a study conducted in our hospital a couple of years back, we found that about 60% or 2/3 of asthma patients had asthma diagnosed after the age of 18 years old. And the incidence of asthma in adults, basically in females, about 5 adults per 1,000 females a year will develop asthma. It's slightly lower in males, where 4 in 1,000 will develop asthma per year. Adults who experience symptoms of asthma, like what I described earlier, for example, wheezing, chest tightness, breathlessness, and cough, they should consult the doctor. And we do have lung function tests that can be performed to confirm the diagnosis of asthma. So the fact is, asthma can start in childhood or adulthood. The third myth, most patients outgrow asthma. This is only true to a certain extent. In children, I'm just going to show you some data from a study conducted in Melbourne. This is the Melbourne asthma study performed in children. And if you can look at the graph here, you can see that how likely a child is to have remission of asthma really depends on how severe the asthma was to start off with. Over at the left-hand column, children with wheezy bronchitis, meaning they just wheeze whenever they have a bit of a cold, a flu, runny nose, about 2/3 of them will have remission of asthma when they grow up. But in children who have persistent childhood asthma, only about 50% will have remission of their asthma. On the right-handmost column, patients with severe, frequent asthma symptoms or exacerbations, only a minority, 15%, will have remission of their asthma as adults. Let's look at the numbers in adults. The proportion of adults who have remission is actually even lower. Only about 3% of adults have remission of their symptoms after 10 years of following up. And so you can actually see that the natural progression, the progression of the asthma persistence in individuals varies quite significantly. On the one hand, you will have a group illustrated here by the dark blue line, where they start having asthma as a child, and they continue to have symptoms even in adulthood. And this is what we call persistent asthma. Most the patients in this group more likely to have, a family history of asthma, of allergies. They may have poor lung function to start off with, may have frequent infections, have allergies themselves, and they may be smoking, and that worsens the problem. There will be another group of patients illustrated in this green line where they develop asthma as a child. The symptoms actually remit when they reach adolescence and adulthood. So they only have childhood asthma. And these kind of patients are more likely to be males and more likely to have mild disease only when they are young. A third group of patients, illustrated here by the light blue line, are those who develop asthma in childhood. They seem to have a resolution of symptoms when they're in adolescent and early adulthood, and the symptoms resurface again when they're older, in older adulthood. And so they may have a dormant state of asthma and a persistent poor lung function, leading to this natural history. And lastly, there will be a group of patients who illustrated by this red line that do not have asthma when they're young and only develop symptoms in adulthood. So they only have adult onset asthma. Patients are more likely to be female, maybe obese, poor lung function. They may have allergies that started when they're older and may be associated with smoking as well. So the fact is, most adults with asthma do not outgrow it, and only some children with asthma outgrow it when they're older. Next myth, asthma is only caused by allergies. So there are actually many different types of asthma. Of course, it's commonly associated with allergies, and it may be related to other conditions like allergic rhinitis, or what we commonly call a sensitive nose, or some patients may recognize it as a sinus problem, or they may have eczema, means like a sensitive skin. But there's also a large group of patients who have non-allergic asthma. So basically, the exact causes of asthma is not known at the moment, but it's likely an interplay of genetic and environmental factors. And these include family history. If somebody has asthma, in a family, they're more likely to develop asthma themselves. Birth history is pretty important. For example, asthma has been associated with preterm delivery, low birth weights, allergic diseases I've alluded to earlier, like allergic rhinitis, a sensitive nose, or eczema. Smoking does play a very important role. For example, if a person whose mother smoked in pregnancy, the child is more likely to develop asthma. Secondhand smoking as well as active smoking. They are both risk factors. Obesity plays a pretty important role in some patients with asthma as well. And in some patients, childhood viral airway infections for certain viruses, they play a part in causing asthma. So the fact is, not all asthma is due to allergies, and there are actually many different factors in play. The next myth, and this is a very dangerous misconception, is that asthma is not fatal. The truth is, based on WHO, the World Health Organization estimates, more than 400,000 people die from asthma each year globally. So during a severe asthma attack, the airways can become so narrow that there's insufficient oxygen that is delivered to the vital organs in the body. And what happens is that some patients, they may end up needing to go to the intensive care unit or ICU. They may need artificial life support system. And, it can be fatal. So some of you may recognize this famous singer. She was a late Taiwanese singer, Teresa Teng, and she has asthma, and she actually passed away from asthma. So the truth is that asthma can kill, and we should treat asthma attacks as seriously as we treat heart attacks. The next myth, some people may think that I have asthma, so it's actually normal to be breathless. It is definitely not normal to feel breathless. And if someone with asthma has frequent episodes of breathlessness, it is actually a sign of poor asthma control. So you have to ask yourself, do you have any of the following symptoms? For example, do you have symptoms in the daytime occurring more than 2 times a week? Do you wake up at night feeling breathless due to asthma at all? Do you have to use your reliever medication more than 2 times a week? Or are you having to limit your activities because of asthma? If you have any of these, actually means that your asthma is not well controlled. Of course, apart from asthma, many other diseases can cause breathlessness as well. And in adults, we'll think about, for example, ischemic heart disease, heart failure, other chronic lung diseases, even anemia. So do seek advice from a doctor if you have persistent or frequent episodes of breathlessness. So the fact is, if you have frequent or persistent breathlessness, it may be asthma control or an indication of other underlying medical conditions, and it's definitely not normal. The next myth: my blue reliever is the most important asthma medication. So I like to say that there's actually two types of inhaler medications in general. One would be what we call relievers, or they are also known as rescue. The other group, it's maintenance medications, or what we call preventers or controllers. So the blue inhaler, what patients commonly recognize as the blue inhaler, contains salbutamol, the medicine salbutamol or Ventolin, and it's a reliever medication. Reliever medications, they relax airways, they open up the airways only temporarily. They have no effect at all on the airway inflammation, and airway inflammation, like I mentioned in my earlier slides, is the most important mechanism driving the asthma process. And paradoxically, excessive use of salbutamol relievers increases the risk of severe asthma attacks and even asthma deaths. However, on the other hand, the maintenance inhalers or controllers, they consist of inhaled corticosteroids. These reduce airway inflammation and provide long-term benefits. So the inhaled corticosteroids, they not only improve asthma symptoms, they prevent asthma attacks and prevent asthma deaths. So they should be used every day as prescribed when well. And it's similar to how patients with diabetes or high blood pressure, they need to take medications every day, even when they feel well. The same goes for inhaled corticosteroids in asthma. So the fact is, inhaled steroids is the most important asthma medication, not the blue reliever. The next myth: inhaled steroids contain steroids and are not safe. I like to stress that inhaled steroids are actually very, very safe because the medications get delivered directly to the lungs, so very little actually gets absorbed into the blood. So patients are not expected to get the typical side effects of steroids, for example, like weight gain, diabetes, osteoporosis, that usually only happens when steroids are taken orally on a regular basis. And patients do not have to worry that they become addicted to inhaled steroids. In fact, if inhaled steroids are not taken as prescribed by the doctors, patients can have uncontrolled asthma, and this leads to them needing to take oral steroids on a regular basis, and that can actually lead to more side effects of steroids instead. Of course, inhaled steroids do have some mild side effects, such as sore throat, hoarse voice, and oral thrush. But these side effects are easily preventable by rinsing your mouth after using the inhaled steroid inhaler. So the fact is, inhaled steroids are very safe and should be taken as prescribed. The next myth: patients may feel that they have no control over their asthma, but there's actually a lot that can be done. So although asthma cannot be cured, it can be well controlled, just like diabetes. So take your maintenance inhaler regularly as instructed by your doctor. Follow your written asthma action plan. Avoid triggers that worsen your asthma, and this varies from patient to patient. Do go for your yearly flu vaccinations, and if you do smoke, it's very important to quit smoking. So the fact is, there are many things you can do to take charge of your asthma and improve your asthma control. Over here, I'm just showing a slide of what a typical written asthma action plan looks like. So it gives instructions on what patients should do when they feel well every day. That's the green zone. When they feel that their asthma symptoms are a little bit worse, and that's in the yellow zone. And when they have very bad symptoms, suggesting an asthma attack, and that's the red zone. So if you do have asthma, do ask your doctor or your pharmacist or your nurse for an asthma action plan. The last myth I'm going to debunk is that patients with asthma should not receive COVID vaccination. And that is not true as well. So what we do know about COVID and asthma so far is that asthmatics are not at an increased risk of COVID infection. In fact, patients with well-controlled asthma are not at an increased risk of COVID-related deaths. as shown by studies. However, the risk of COVID-related deaths is increased in patients if their asthma is poorly controlled or if they have severe asthma. So in general, allergic reactions to COVID vaccines are rare, and COVID vaccination is recommended for patients with asthma who do not have any other vaccine contraindications. So if you have asthma, you can receive your COVID vaccination. So I'd just like to summarize some take-home messages from the 10 myths that I've just talked about. Firstly, not all patients with asthma have wheezing. Secondly, asthma can start in adulthood and it's not just a childhood disease. Thirdly, asthma is a chronic disease, as most adults do not outgrow asthma, but it can be well controlled. Fourthly, not all asthma is due to allergies. There are actually many factors at play. And very important, asthma can kill, so please do take it seriously. Number 6, frequent episodes of breathlessness is not normal in asthma, so do see a doctor and get evaluated early. Inhaled corticosteroids is the most important asthma medication. Take it as prescribed even when you feel well. They are very safe. Inhaled steroids are very safe. And you have many things that you can do to take charge of your asthma and lead a healthy lifestyle. And finally, patients with asthma can receive COVID vaccination, so do go ahead with it. I'd like to end my session. I'll be happy to take any questions. Please type them in the Q&A chat and we'll answer them at the Q&A session. So now I'll pass the time over back to Dr. Anthony E. Anthony, over to you.
Yes, thank you, Tunn, for that very interesting and stimulating talk on common myths and misconceptions of asthma. I do see a few of our attendees raising their hands. If you do have any questions or clarifications, please do type them in the Q&A function and we will address them after all 3 panelists have spoken. I also see some existing questions that have been typed in the Q&A box. Thank you. Please keep those questions coming in and we will address them later. Now I'd like to move on to our next speaker, Dr. Victor Tunn. Dr. Victor Tunn is an internal medicine specialist here at our hospital. He graduated from the Yong Ludin School of Medicine in 2009, and he is currently pursuing further specialization in sports and exercise medicine with our Sports and Exercise Medicine Center. Dr. Tunn has a keen interest in weight management and the application of exercise in the prevention and treatment of chronic diseases. Dr. Tunn will be clarifying concerns on exercise and asthma control so you can breathe easy while exercising. So Dr. Tunn, please, over to you.
Okay, hi. Can everyone hear me?
Yes, we can hear you, Victor.
Yeah. Thank you, Anthony, for the kind introduction. My name is Victor here, and I'm from the Department of Sports Medicine in Changi Hospital. And today I'll be speaking to you on the topic of can I exercise if I have asthma? So without much further ado, I shall start my presentation. Okay, so some of the objectives we'll cover today here. That will be on what is asthma, what is exercise-induced bronchoconstriction, prevalence of exercise-induced bronchoconstriction, benefits of exercise and asthma, perhaps how to start exercising, and some of the things to take note before and during exercise. As Dr. Tay has touched on asthma, I will not be elaborating too much on that topic. And I will be covering more of the new topic of exercise-induced asthma or exercise-induced bronchoconstriction. So just to recap, Asthma is a chronic inflammatory disease that covers these few symptoms mainly. One of coughing, second, chest tightness, shortness of breath, and wheezing. What I would like to highlight from this slide is that most guidelines seems to somehow include asthma as a potential trigger for asthma, which may be which is correct in itself. But the issue here is whether exercise truly triggers asthma the way usually allergens do. So I'll be touching more about how exercise may potentially trigger asthma later, and hope that you may see some difference between asthma and allergens as a cause for asthma. But however, the bigger problem I'd like to highlight here is not exercise triggering asthma, but rather the problems of not exercising in itself. So many studies have also shown that parents restrict kids from exercising, and as a result, these kids develop poor cardiovascular fitness, and poor cardiovascular fitness actually correlates to earlier death in the future years. Also, when children do not exercise, they tend to become obese, and when they become obese, it becomes a risk factor in itself for asthma again, and this cycle goes round in a circle, and that makes asthma control even worse. So I'd like to introduce a new terminology called exercise-induced bronchoconstriction. So bronchoconstriction means airway narrowing, and hence exercise-induced bronchoconstriction simply means transient airway narrowing that occurs usually during and most often after exercise. So now, what is this exercise-induced bronchoconstriction and exercise-induced asthma? Essentially, they are actually the same terminologies. So in patients with chronic asthma, both exercise-induced asthma or EIA and exercise-induced bronchospasm or exercise-induced bronchoconstrictions are used interchangeably to describe the airway narrowing that occurs during and after exercise activity. So exercise-induced asthma is usually used to describe this narrowing as well, but the wording is potentially misleading because what happens is that it seems to imply that exercise causes rather than exacerbate or trigger an attack of asthma. Yeah, in fact, exercise actually may be helpful in preventing the onset of asthma in children. Yeah, so for any doctors who happen to be in this audience, it's important to distinguish patients in which the symptoms are triggered only by exercise versus patients with chronic asthma who also happen to have exercise-induced bronchoconstriction. So from here on, I'll be using the term EIB to stand for exercise-induced bronchoconstriction rather than exercise-induced asthma. So let's just talk about some of the prevalence of EIB over here. So in general, worldwide, 5 to 20% of the population do have some form of exercise-induced bronchoconstrictions. However, the number goes up even more in the asthmatics, where 90% of the asthmatics actually do have some symptoms or presentation of exercise-induced bronchoconstriction. More so, the prevalence actually appears to be higher in elite athletes, and I'll explain later on why. Amongst all the different sports, just to mention, 18% 18% of the swimmers happen to have EIB, 16% of the cyclists have EIB, and triathletes up to 12% of them. However, if you do notice, some of the other sports, such as gymnastics, fencing, and sailing, they have a slightly smaller proportion of the athletes who have EIB, about less than 5%. All these numbers are taken from previous numbers in the International Olympic Federation during the past Olympics. And in patients who actually gone through testing called the eucapnic hyperventilation, up to 39% of the swimmers actually do have EIB. And the prevalence is also equally high, 24% in winter sport athletes, and we'll go through why as well. So this is another paper just to show amongst the kids, general population of kids worldwide, It's about 9% for those with EIB. And the number goes up actually for Asian Pacific children and American children, up to 12%. And amongst amongst the athletes, 15% have EIB, whereas those with asthma, up to 46% of the children has EIB as well. And around the world, there's about approximately 16.5 million children who may have EIB symptoms. So that's quite a lot of number. So we'll go through the reason why. I'll try to slow down and explain this slide. So usually all of us will tend to breathe through our air, breathe in air through our nose. And this process helps to warm and humidify the air as it travels from the nose all the way to our airway. However, during exercise, it's natural that we tend to breathe in more and more quickly and with the use of our mouth as well. So this results in air that is cooler and drier that goes through the mouth and straight to our airways. As a result of this quick flow of air from the mouth to our airways become very cool and dry easily. And this causes our airways to actually cough as a reflex to help moisten the airway. Also, the dry air causes a thin layer of the fluid lining to become thickened, and this layer causes mast cell degranulation or triggers the asthma pathway and release all the mediators, and this concomitantly causes narrowing of the airways. As such, people with sensitive airways tend to have this bronchospasm earlier, and this will lead to coughing, wheezing, and chest tightness, if you may recall, and these are also symptoms of asthma in itself. So this pathway is also the reason why we tend to cough and become slightly more breathless when we are running very hard on the treadmill, especially in a cold aircon gym, or even if we run or ski in the cold winter air. So in a landmark study to find out about the patients with EIB and how they feel, okay, so this paper was done in 2011. So asthmatic patients with symptoms of exercise-induced bronchoconstriction actually have a significant emotional and psychological burden of disease. And they actually feel more fearful and isolated and frustrated than patients without EIB symptoms when they start to exercise. Nearly half of the asthma patients report that their health interferes with their ability to perform well in sports. And up to 1/3 feel that they cannot keep up with their sports as a result when they compare to their peers. Also, when asked what triggers their asthma, they seem to volunteer the term exercise more than any other asthma trigger. However, when asked what do they do to take control of their symptoms, less than 25% actually mentioned that they take the quick reliever medicine called salbutamol, which I have it here. Yeah, this is the blue reliever. And as a result, they do not try to preempt their symptoms. And also the results of this survey actually do suggest that as for exercise-related symptoms amongst asthma patients, actually reflect that it may actually be uncontrolled or improperly managed asthma and EIB rather than the exercise in itself causing the symptoms. So the take-home message over here is that exercise-related symptoms amongst asthma patients actually do reflect that the control may be poor instead. So now that we know uncontrolled and improperly managed asthma plays a part in EIB, how does exercise help with asthma? So this is a 2020 GINA report in which most respiratory physicians follow in terms of the guidelines. And it has been suggested that physical activity do be given to patients with asthma. So in the report, it encourages people with asthma to actually engage in regular physical activity for regular health benefits, and also to provide advice for prevention of exercise-induced bronchoconstriction, perhaps with regular inhaled corticosteroids. provide advice for prevention of breakthrough EIB with either warm-up before exercise, the blue reliever before exercise, and perhaps the use of the inhaled corticosteroids as well. And because regular physical activity improves cardiopulmonary fitness, it is advised to be given to patients. Also, in the same report, there's advice for weight reduction, advice to be given to patients as well. So why do asthmatics need to exercise? So several papers have mentioned a few reasons, and we'll go through them. So the first paper actually mentions that physical activity in asthma was lower than people who do not have asthma. And as a result, patients who have higher level of physical activity actually have better measures of lung function, disease control, and health status. And they actually utilize healthcare less. So the benefits of exercise will include that in the ACT score, where it's a performance score for patients with asthma, they tend to be better than participants who do not exercise. So exercise also reduces the use of the asthma rescue medication, and it helps to improve the shortness of breath symptoms that they feel. Also, physical training improves the cardiopulmonary fitness of these patients and have positive effects of health-related quality of life outcomes. For patients who exercise, there's also improvements in the days without asthma symptoms. There are improvements in FEV1, which is one of the measures for improvements in asthma, as well as overall exercise capacity. In patients who have weight loss versus patients who do not undergo weight loss with exercise, so patients who exercise and go through weight loss at the same time, they have a significant increase in the number of asthma-free days. They also have improvements in depression symptoms, and they have lower risk of developing obstructive sleep apnea and difficulty sleeping at night. So there's an improvement in the overall sleep efficiency as well. So this slide is just to go through some of the famous athletes out there who actually have asthma. So this first lady, her name is Jackie Kersey. So she's a track and field star and a 4-time Olympian, and was actually diagnosed to have asthma as a freshman in her college years. This next famous lady is Paula Radcliffe. She's a British long-distance runner, and she has done this 7 times, and she's the world champion 7 times as well. She's the current world record holder in marathon, and she was also diagnosed to have exercise-induced bronchoconstriction when she was young. Next lady is Justine Henin. She has won multiple Grand Slams in the tennis, and she has currently retired. And this is another famous soccer player for all Manchester United fans. His name is Paul Scholes, and he's also a patient who has exercise-induced bronchoconstriction too. Lastly, for all soccer fans out there, I do not need to introduce this gentleman. His name is David Beckham, and he's also photographed to be using inhaler during his soccer activity as well. So I would like to come down to the more important slides of the principles of exercise in asthma. So firstly, before we start exercising, we need to make sure that the diagnosis of asthma is correct. And for patients who have symptoms that were similar to that of asthma, perhaps to visit a physician and make sure that the diagnosis is correct and accurate and being treated first. So next is also to understand the triggers and symptoms for your asthma and to make sure that they are adequately controlled. For patients who have a peak flow meter, the monitoring of peak flow pre-exercise, during exercise, or even post-exercise could be a measure of how they are doing during exercise and their control of asthma. We'll go through some of the warm-up exercises later, but in general, it's advised for patients to start off with light to moderate easy warm-up exercises. And lastly, to perhaps consider exercising in slightly warmer temperature. As mentioned, cold, dry air environments tend to trigger exercise-induced bronchoconstriction easier. So what types of exercise can we choose? Actually, any form of exercise that you prefer is the best exercise. However, of course, there are some exercises that are perhaps slightly preferred. For example, swimming, because these subjects do not need to breathe in and exchange large amount of cold, dry air at any point in time. Yeah. However, a word of caution is that because chlorine in the water may sometimes induce exercise-induced bronchoconstriction or asthma, for those who are very sensitive to chlorine, you may want to consider non-chlorinated pool if there is any out there. Jogging and running are actually allowed, but again, the first principle of exercising and warming up at low intensity lies. So how much do we need to exercise? In general, it's preferred that any patient out there exercise up to about 3 to 5 times or even daily. And the intensity of exercise would generally be light to moderate, with moderate being preferred over light. Over time, for the amount of exercise, it's preferred that each session lasts for at least 30 minutes or up to 60 minutes. And the exercise will include aerobic activities involving large muscle groups. Moderate intensity in general means to exercise at a pace where you can sweat and you can and you're breathing slightly difficult, but still able to slightly talk to the person next door. So this is also just to show the guidelines under the ACSM or the American College of Sports Medicine. So in general, it's preferred for 150 minutes of moderate intensity exercise activities or 75 minutes of vigorous intensity exercise minutes. So moderate intensity, again, it means raised heart rate, feeling warmer and breathing faster, but not to the point of breathless. Where vigorous intensity means having difficulty talking, very rapid breathing, and putting in much more effort. It's also preferred that patients do go through some form of strength or resistance trainings for at least 2 days in a week to help improve overall muscle function and prevent injury and to just get overall balance. The whole idea is just at the end of the day to sit less and move more. For children, we have a slightly different guidelines. For children who are able to exercise and who have adequate control of their symptoms, it is preferred that they exercise daily for at least 60 minutes or more, with up to 3 days being vigorous in intensity. Yeah, so some of the things to take note of when we start exercising. So first, that of a warmer temperature, and hence the mid-morning may be preferred because of the warm air that moves in and out of the airways. It's much easier for the airways to tolerate that. Humidity may play a role for us, and we are slightly fortunate in that sense that we are in a bit more humid climate, which may actually favor us when we start exercising. Because cold, dry air at the end of the day may trigger exercise-induced bronchoconstriction much easier. Of course, if a patient has asthma, it's best to avoid hazy days or environments which have much more allergens, such as pollen, even construction site, dust mites, and so on and so forth. The whole principle of start low, start slow, take it easy matters over here. Because what we do need is low intensity of warm-up exercise activities to ensure that the airway gets used to that movement of the air before we start taking on harder exercise. Yeah, and also it's preferred that probably you exercise with a friend out there so that there's another person to look out for your symptoms. Lastly, again, carry your blue inhaler. So for those who have been diagnosed with asthma or even exercise-induced bronchoconstriction, something to take note that is you might want to actually use your inhaler two puffs, about 10 to 15 minutes before starting your exercise. Yeah. In terms of the warm-up exercise, some of the suggestions could be that you take part in 10 to 15 minutes calisthenics stretching to reach about 50 or 60% of your maximum heart rate to reduce the chance of exercise-induced bronchoconstriction occurring. Usually, symptoms occur about 10 to 15 minutes after maximum exertion. For some people, it may be earlier, between 6 to 10 minutes. Most of the time, for patients who actually run very hard, their symptoms may occur only after the exercise activities. So if such symptoms do occur and you happen to have your blue inhaler, you may also want to consider to take it as well to relieve of the shortness of breath symptoms. This paper is just to show what we were talking about just now, that cool, dry air matters. So in this paper, what happens was they have a group of people who exercise in cold, dry air, and people who exercise with the use of a heat and moisture exchanger. And it shows that intense cold air exercise actually cause transient acute bronchoconstriction and symptoms of cough in individuals who actually participate in winter sports. So some of the other strategies that that you can think of, and sometimes I actually do advise my patient of, would be the use of a mask to exercise to allow for the inflow of air to be warmer. This mask is preferred to actually cover the nose and the mouth as well. Also, for patients who actually see soccer players who train in the winter, they actually have the use of what we call snoots that cover all the way until the nose to actually help to breathe in warm air as well. So these are just some suggestions that you may use if you prefer, although you have to be mindful that our warm weather can make it quite hot and dehydration might be an issue as well. Just for the clinicians out there, just an additional thing to take note of, because quite a lot of our swimmers actually do have asthma, and they are seeing respiratory physicians in the private and public sector. Do note that inhaled beta-2 agonists or the blue inhalers and the inhaled corticosteroids are actually allowed under the WADA or World Anti-Doping Agency guidelines. But this is only limited to treatment dosage or up to 16 blue color puffs in a day. However, for patients who have very poor control of asthma and who require the use of oral salbutamol or beta-2 agonists or the use of oral corticosteroids, this is actually not allowed and is banned. So should they actually require the use of these medications while participating in international events, they actually require the use of therapeutic use exemption. So for clinicians who are not so clear about this rule, you may want to actually refer to us for this on the sports physician side. So in summary, we have gone through this terminology of exercise-induced bronchoconstriction, how exercise is important in managing asthma, how exercise actually has real benefits for asthmatic patients, and we have also gone through the exercise. Asthma needs to be adequately controlled before engaging in exercise. In choosing exercise, choose one that you can manage and control well. And the good old advice of start slow, go slow matters over here. Try to avoid exercise in places with cold, dry air at the beginning and do warm-ups for 10 to 15 minutes prior. However, if you have any doubts about the exercise-induced bronchoconstriction, whether your symptoms are in keeping with asthma or exercise-induced bronchoconstriction, please feel free to speak to any respiratory or sports physician about it. So thank you. I leave my email here for anyone who have questions and would prefer to email instead. So we'll take questions later on in the Q&A session. Thank you very much.
Thank you very much, Victor, for those very useful and practical tips on how to manage exercise activities when someone has asthma. And felt that it was very encouraging that you showed the slides of the various elite athletes, all of whom have won accolades for their sporting performance despite having asthma. And I think that's a very important take-home point that we want to try to drive here, is that even with asthma, it is possible to undergo treatment and have the asthma so well controlled that it's possible to live productive lives, and in fact a normal life with the appropriate treatment. Okay, and I do see some questions on exercise in the Q&A box. Please keep your questions coming. Next, we move on to our talk on smoking and why you should quit smoking and how it affects asthma. Our presenter for this talk will be Ms. Vivien Wong. She is a pharmacist with us here, and she has a bachelor's degree with honors in pharmacy from NUS and is a certified quit smoking consultant. Her professional interests are in patient-centric care in the hospital and in community. She currently works at the Smoking Cessation Clinic and Medication Therapy Management Clinic in CGH. And she brings to us a wealth of experience in terms of practical tips as well as practical methods to stop smoking. Vivien, I'll hand over to you.
Thank you, Dr. E, for the kind introduction. Good afternoon, everybody. I'm Vivien, a pharmacist in practice and also currently part of a team of certified quit smoking consultants made up of pharmacists and nurses. You might have seen me before in the pharmacy or in the clinics, and today I'm here, very privileged and excited to share with you something that I'm very passionate about and very convinced of. So in my talk today, we will debunk common misconceptions about smoking and also how one can quit smoking. More often than not, when we run smoking cessation clinics, we hear patients making statements such as the following: I'm already so old, doesn't make any difference if I quit now. My friend smoked for so long, also nothing happened, so it's okay to continue. I've been smoking for so many years. It's not something that I can quit now. My grandmother smoked for her whole life and she lived to 90 years old. I've seen my friends, relatives falling ill, passing away as soon as they quit smoking. So I cannot quit. So before we go straight to debunk these statements, let's start with the first segment of my talk, where we'll discover together tobacco facts, familiar yet unfamiliar, and also health effects of active and passive smoking. So let's begin. Today, smoking continues to kill its users when it's used entirely as intended. In Singapore, every week, smoking kills 33 men and 10 women, summing up to over 2,200 Singaporeans yearly. Still, over 2,000 children aged between 10 to 14 years old and close to 400,000 adults above 15 years old continue to smoke each day. Smoking exposes individuals to a lethal mixture of more than 7,000 toxic chemicals, including at least 70 known carcinogens that can damage nearly every organ system in the human body. Carcinogens are cancer-causing substances found in tar, which is a mixture that forms a sticky mass in the lungs. So when an individual smokes, the tar level increases in the lungs, with the last pass containing as much as twice the amount of tar in the first puff. Second, carbon monoxide. Carbon monoxide, commonly found in car exhaust fumes, when inhaled, combines with your red blood cells and reduces their ability to transport the much needed oxygen to the rest of your body. This damages blood vessel linings and increases cholesterol deposited in the blood vessels, increasing your risk of heart diseases. Carbon monoxide toxicity is also commonly linked with lung diseases such as asthma and chronic obstructive pulmonary disease, in short COPD, In short, we will be actually touching them in the next few slides. Our smoking cessation clinic sessions here are also equipped with what we call smoker lasers to help track the carbon monoxide levels in the body over our patient smoking cessation journey with us. Third, nicotine. Nicotine, which many will have known, is the chemical that makes smoking so addictive. Right? It increases the heart rate, blood pressure, and also oxygen demand for heart muscles, which may result in heart diseases and heart attacks. Lastly, irritant substances. Irritant substances destroys the cleansing layer in the lungs and causes the buildup of mucus, resulting in cough and also asthma, COPD, and lung infections. With the significant number of smokers continuing to smoke daily, smoking remains the single most preventable cause of death, killing both active smokers and passive smokers alike. Active smoking is commonly associated with many immediate adverse health consequences, including addiction, and accelerates the development of chronic diseases over the full life course, including heart and lung diseases and other well-known consequences. Similarly, passive smoking is also associated with increased risk of cancer and heart diseases and other health effects. Most of the damage to health does not become evident until years or even decades after the onset of use. With the limited time in today's talk, we will be focusing on specifically the lung diseases and the heart diseases. Let's start with asthma. Active smoking unfortunately places smokers at significantly increased risk of developing asthma, with increased airway inflammation and obstruction. It is associated with increased risk of poor asthma control, lung infections, and hospitalizations. It also reduces the effectiveness of inhaled and oral corticosteroids. As covered by Dr. Tay, the inhaled corticosteroids are the mainstay of treatment for asthma for their anti-inflammatory effects. Persistently, with increased decline of lung function, this may also lead to COPD, particularly in older and ex-smokers. Asthmatic smokers who quit had significant reduction in airway inflammation and improvement in lung function and asthma-related quality of life. Smoking, as briefly mentioned, is also a risk factor for developing COPD, a type of lung disease that is progressively disabling. In Singapore, COPD is the 7th most common cause of death and hospitalization. The likelihood of developing COPD increases with increasing age. Most smokers develop some form of lung impairment, and 50% of smokers eventually develop COPD. Yet many remain undiagnosed, continue to experience high levels of symptoms, and compromised quality of life. Sadly, when diagnosed, many stop while some continue to smoke. Smoking induces inflammation in the lung and its airway. The airways become narrowed and the air sacs get destroyed by the smoke, thereby making breathing more and more difficult. Smoking progressively and gradually destroys the lungs and causes the decline in lung function. The breathlessness is rarely troublesome before half the lung has been damaged. But once damage is already done, the body will not revert to its mean condition, even if you quit smoking. Nonetheless, smoking cessation is the single most effective and cost-effective preventive measure and treatment for COPD. It is beneficial in slowing down the progression, and abstinence from smoking leads to marked reduction of its symptoms. Moving on to the notorious lung cancer. Inhalation of cigarette smoke can damage the lungs in 2 ways. First, smoke destroys an important cleansing layer in the lungs. This prevents the lungs from getting rid of foreign and harmful substances and causes the buildup of mucus. When the lungs try to clear this mucus, this results in the smoker's high cough. Second, cancer-causing particles from the smoke that are lodged in the mucus facilitate the development of cancerous tumors. Sadly, lung cancer patients have less than 10% of surviving beyond 5 years after contracting the cancer. The lifetime risk of developing lung cancer is 1% for non-smokers and 30% for heavy smokers. Nonetheless, the risk of contracting lung cancer decreases when smokers give up the habit of smoking. Yet, despite an abstinence of 30 years, ex-smokers still have a risk level above that of those who have never smoked. Recall previously in the content of cigarette smoke, where we discussed on increased heart rate, elevated blood pressure, and raised carbon monoxide levels in the body. While this not only damages blood vessel linings and increases cholesterol levels, but also makes blood stickier, causing blood clots to form and block blood vessels. This increases the likelihood of heart diseases by 3 to 4 times. In addition, we block blood vessels in the brain. This cuts off blood supply to the surrounding brain cells and causes them to die, resulting in stroke. Smokers are twice as likely to suffer from stroke compared to non-smokers. The likelihood increases with the number of sticks smoked, where heavy smokers of more than 40 sticks daily have twice the risk of stroke compared to light smokers of up to 10 sticks daily. However, the good news is the recovery process begins almost immediately when one stops smoking, and the risk reduces to the same as non-smokers within 5 to 15 years after abstinence. As we move from active smoking to passive smoking, I recall a statement made by a patient that I've seen recently, saying that it's all right that I smoke outside the house, as it will not affect his family members. Unfortunately, smoking outside the home does not fully protect your family members from the harmful effects of smoking. Secondhand smoke can be found in dust, on furniture and other surfaces, what we term as third-hand smoke, and exposes your family members to levels equivalent to several hours of active smoking. For instance, studies have shown that children exposed to second-hand and third-hand smoke are more likely to suffer from asthmatic symptoms, and that children with asthma had more doctor visits, more frequent flares, and greater asthma severity. There are also suggestive evidence of long-lasting damage to the lungs from childhood exposure. In addition, childhood exposure to cigarette smoke may influence smoking behavior later in life. Studies have shown that social influences, including parents, your loved ones, friends who smoke, play a major role in youth smoking uptake. Conclusively, there is no safe level of exposure, active smoking and passive smoking alike. Nevertheless, it is never too late to stop smoking. Remember, the recovery process begins almost immediately when one stops smoking. Let me walk you through the recovery process. Just 20 minutes right after you stop smoking, your blood pressure and heart rate decrease and return to normal. After 8 hours, the amount of carbon monoxide decreases, drops back to normal, while the amount of oxygen in your body returns and increases to normal. After 48 hours, your nerve ending begins to regenerate and you can start to smell and taste things better. After 1 to 9 months, the coughing, sinus congestions, fatigue, shortness of breath decrease. After 1 year, your heart disease risk declines to half of that of a smoker. After 5 years, your stroke risk may be reduced to that of someone who have never smoked. After 10 years, your risk of smoking-related cancer reduces to up to 50%, and after 15 years, your heart disease risk is now similar to that of someone who have never smoked. While you might have heard before that smoking makes the poor poorer, taking away not only their health but also their wealth. Therefore, quitting smoking not only saves lives but also your money. So to end off the first segment of my talk, let's try to debunk the earlier statements. Just in the previous slide, we have ascertained that quitting smoking is never too late. All age groups suffer from long-term and short-term consequences of smoking. Therefore, the sooner you quit, the sooner your health can improve, and the more you reduce your chances of getting cancer and other diseases. As smoking-related diseases often develop over a number of years before a diagnosis is made, there is no way of predicting who will be killed next by their smoking habits. He or she might just have got lucky. Well, let's move on to the next segment of my talk. Before you attend today's talk, you probably have known someone who smokes, perhaps a family member or a good friend, and you wonder to yourself why he or she will not stop smoking. Well, fighting the urge to smoke and quitting smoking for good isn't easy. It simply isn't a matter of determination. Frequently, we have patients in clinics who ask for medication that will make them stop smoking. Often, we also get statements such as, quitting smoking is all about willpower, that it's good enough to just reduce my smoking, and the concerns that they will be addicted to the medications given to quit smoking. Right, before we begin to debunk this set of statements, let's unveil the quit plan together. We call nicotine as the chemical that makes smoking so addictive. Many people still smoke even though they know that smoking is bad for them, thereby continue to affect not only their lives and their health, but also their families and friends in unhealthy ways. So how does nicotine make smoking so addictive? With each inhalation, the nicotine reaches the brain in just 10 seconds, acting on the nervous system and altering moods, appetites, and alertness in ways that are pleasant to the smokers. And when the nicotine gets cleared from the body craves once more for the pleasure from smoking, creating a vicious cycle. The repeated nicotine hits to the brain contribute significantly to its highly addictive nature. Therefore, because one, nicotine dependence is a strong addiction, and that two, smoking is related to the feeling of pleasure, smoking often becomes a lifelong habit and makes quitting extremely difficult. Sadly, it is no surprise that interventions with willpower only often results in modest success. Therefore, it is essential that we are specific with your quit plan. First, we have to identify your motivations for smoking. It could be any of the following three or a combination. First up, craving-prone smokers. Craving-prone smokers normally crave for the nicotine in the cigarettes, and they tend to feel weak if they don't smoke, or they can't get through the day without lighting up a cigarette. Next, stress smokers. Stress smokers, on the other hand, smoke to distract themselves from their problem or as a way to cope with their stress. Lastly, creature of habits. Creature of habit smokers generally smoke at certain places, at certain times, or even with certain individuals. Right, after we have identified your motivations for smoking, we need you to write down your reasons for quitting and to constantly remind yourself of the reasons you're trying to quit for. Thereafter, to choose a quit method and also to set a quit date. Well, there are generally two different quit methods, the cold turkey and the gradual reduction. In cold turkey, you would stop completely from your proposed quit date onwards, whereas in gradual reduction, you would gradually reduce your number of sticks on a day-by-day or week-by-week basis. Comparatively, gradual reduction may be more tiring once you actually reach 5 to 10 sticks. And recall that smoking of any amount of cigarettes still has a higher risk of getting cancers and other diseases. Nonetheless, it is of no wrong that you choose gradual reduction over cold turkey. Ultimately, this is your quit plan and you determine your rules. So once you've chosen the quit methods and quit date, start preparing for it. Throw away all your lighters, your ashtrays, and cigarettes, or have them hidden in your post box under your house. And remember to tell your loved ones to garner their support in your journey. It is normal to experience some cravings and withdrawal symptoms when you quit smoking. Such withdrawal symptoms include feelings of irritability, headache, tiredness, coughing, and tingling of the hands and feet. But not everyone will experience these symptoms. And do not lose heart if you do. Always remember that these symptoms are only temporary. Withdrawal symptoms may be experienced as quickly as 4 hours after your last cigarette and generally strongest at 3 to 5 days before diminishing after 2 to 4 weeks. You can learn to cope with your withdrawal symptoms by practicing 4Ds and most importantly with ample rest. While 4Ds are not your everyday lottery, they refer to 1, distracting, 2, delaying, 3, deep breathing, and 4, drinking. So for example, when you feel a strong urge, you can try to distract yourself by doing something else, such as calling a friend, taking a shower, or munching on some healthy snacks. The urge to smoke usually lasts for 3 to 5 minutes, so try to wait it out, what we term as delaying. You can also try to relax quickly by taking deep breaths or drinking water or milk slowly. You can also contact your doctors or pharmacists for medications to cope with your withdrawal symptoms to help you in your smoking cessation journey. Quitting smoking, of no doubt, it is a difficult process. In fact, most smokers try to set a quit date and quit many times before they actually manage to quit permanently. That's why anyone that actually try to quit needs as much help and support as possible, and you can help them and encourage them. So this is actually a simple 4-step guide. First, help them to understand why they smoke. Be unconditionally positive, open, warm, and genuine. Do not nag, scold, or threaten them. They do not work as they become more defensive. Select an appropriate time and place to actually bring out this topic. For example, over a meal, when chilling out, or out for an evening walk with them. Gauge their attitudes and offer help accordingly. Sadly, occasional cravings may persist for as long as several years after quitting permanently. Hence, slip-ups can easily and do happen, but do not be discouraged. Sometimes it does take more than one quitting attempt, but do not stop trying if you do. If you can remain abstinent for 6 months, relapse is actually generally unlikely. So before we end my presentation, let's debunk the last set of statements together. Recall that quitting smoking is extremely difficult, and intervention with willpower alone only results in modest success. Reducing cigarette consumption, no doubt, will actually significantly, slightly reduce your risk, but cutting back is just not enough to protect you. Quitting is the only way to long-term health benefits. Medications may be prescribed to help you to cope with your withdrawal symptoms. However, these medications are no miracle pills. They are normally taken for a short duration of time, and they do not make people addicted to it or to stop smoking. Well, that's all I prepared to present. Thank you so much. If you have any questions, please feel free to in the Q&A panel. I will be more happy to take up your questions. Thank you all for your time. I'll now hand back over to Dr. Yee.
Yes, thank you, Vivien. So we have come to the end of our presentations, and we'll now begin with our question and answer session. Just looking through the questions, we have a question on whether vegans are less likely to have asthma, or at least if a vegan diet relieves asthma. Perhaps I could just reframe the question, whether or not there's any role for dietary interventions in asthma. And this question I'll direct to Dr. Tay.
Yes. Hi, Neil. Thank you for your question. It is a very interesting question. So we don't have any conclusive studies yet that shows that a change in diet will alter the course or whether it delays the onset or prevents the onset of asthma. But is it possible? Definitely, there's a potential. Why? It's because I mentioned about inflammation as a driver of asthma in our airways. So we do know that there's some studies showing diet can affect inflammation in our body, in the airways. It can change the bacterial constitution in our body as well. So it is possible that some patients may feel that a change in diet or certain diets may help with their symptoms. But do we conclusively have that data? We don't have yet.
Okay, thank you, Tunn. There's another interesting question from one of our attendees. Given the latest convergence between traditional Chinese medicine and Western medicine, are there any herbs that can be bought over at the neighborhood shops? What about Western herbs that build up lungs? Do these have a role in asthma? Maybe you could help shed some light on that, Tunn. Yes, I think we are experiencing some technical difficulties. Wendy, I will leave the question aside for now, and we will pose it again if we can get Dr. Tay back on the line. Perhaps I'll next move on to some questions that can be answered by Dr. Tunn with regards to exercise. So we have an attendee who's 90 years old with a long-standing asthma that is under control. And the question posed is, as my knees are worn out, I do stationary bicycling for 1 kilometer, which makes me somewhat breathless. Should I be content with that or aim for more? So I guess just to rephrase the question. How does one go about pacing the exercise in asthma?
Hey, hi, thanks, Anthony, and thanks, Mr. Krishnamurti, for your question. So I think the most important thing here would be to just make sure that the breathlessness that you experience during the exercise is probably not something due to anything pulmonary or cardiovascular first, all right? So making sure that you do not have poorly controlled asthma, or could it be some form of cardiac diseases that might be going on. And if so, once that is cleared, perhaps in terms of the stationary cycling, there are many factors to look at. One, it could be because the amount of resistance that you put on to the stationary bike cycle, is it too tough for you? Could it also be that your seat height is too low, and as a result, you are actually pedaling harder and more? And perhaps another thing to look at is to actually reduce the intensity of how much you are cycling, and instead go long and go slow could be another way out of getting the exercise in, rather than making yourself more injured or more breathless during this period of time. I hope I answered that question for you.
Yes, thank you, Victor. We have another question that you might be well placed to answer. During haze conditions, should a 65-year-old still daily brisk walk with a mask? And if so, are there masks which are suitable? Can they be bought online?
Yeah, thanks for the question, Wendy. So what happens is that we actually did our own study, but unfortunately amongst our own physicians with mask, okay? So what happens is that during hazy conditions, I think brisk walking with a mask is not wrong, as long as it's tolerable for you and the pace is not too breathless. Wearing a mask to actually brisk walk is not wrong, and it's doable in fact, all right? But probably one suggestion in the type of use of mask will be that perhaps you do not want to use a surgical mask, because when your face gets wet and moist, the surgical mask will also become wet, and instead of being comfortable, it can make it more uncomfortable during your brisk walking and makes breathing that little bit harder. So perhaps a consideration is that you can use other types of cloth masks, or maybe some form of a sports mask like this, all right? And yeah, to just make your walking more easy. So yes, they can be bought online, but there are various types of masks that's out there. In essence, just make sure that you're wearing one that makes you more comfortable.
Okay, thank you, Victor. I think Dr. Tay is back online with us. So Dr. Tay, can you answer the question about whether traditional Chinese medicines, Western herbs, and there's also a question on crocodile soup, whether this will help to relieve or treat asthma?
Yes, thank you for the question. With regards to whether there's any Western herbs to build up the lungs or for asthma, we don't really have much data on that. What about Chinese medications? Sometimes we're a little bit hesitant to encourage the use of traditional medications, because sometimes we don't know what really goes into them. They may actually contain steroids, and that's why some patients may feel better after taking these medications. But as I mentioned previously, inhaled steroids are very safe, but oral steroids, they can cause long-term side effects of steroids, for example, diabetes, osteoporosis, reduce the immunity, and that in itself is dangerous. So I wouldn't go as far as to say that we should start trying to use traditional medications. We just don't have enough data, and for traditional medicine, we really sometimes are not sure what's in them. As for crocodile meat or soup, I don't really know the data for that, but I do know, that's what a lot of our mothers tell us to drink. I mean, I don't think it's going to be a problem if that's to your taste, but if does it really help asthma? I'm not very sure. Thank you.
Okay, thank you. Personally, I also have a question on smoking that I commonly get from patients, and maybe Vivien, you could help to shed some light on this. So it's quite common to see patients or individuals with lung conditions come in with multiple attempts to have quit smoking in the past, but eventually would relapse. Can you shed some light on some of the strategies that we can use for such individuals?
Thank you so much. Right. So actually, relapse is actually part of a natural process of quitting smoking. So actually, stats have shown that most people require about 5 to 7 tries before they can actually stop smoking permanently. They are actually useful to help you identify situations or triggers that actually associated with smoking. So it actually helps you to actually better prepare for you in your subsequent quit attempts. Therefore, never think of your these attempts as such sort of a failure, instead as like practice sessions. So with that, it actually helps you to have better chances of succeeding at the next chance. Right. Thank you so much. Hopefully that clarifies.
Okay, thank you. I think we have time for one last question. And I think that question relates to using asthma inhaler puffs just prior to exercise. Is 2 puffs enough? Or can I take more puffs during exercise if I'm still feeling breathless? Perhaps, Victor, you could shed some light on that.
Hi, thanks for that. So I've answered that question, but I will probably answer here live as well. So there are many reasons why somebody may be feeling breathless during just before they exercise. Could it be an issue of a poorly controlled asthma? Or could it be any other cardiac conditions that may be out there? Or perhaps it may be something else as well. So it is tricky to answer definitively whether just using the puffs could help abate the issues. So my advice is that if taking 2 puffs before the exercise doesn't seem to do well, and you are still slightly breathless before your exercise, my suggestion would be that to actually visit a doctor or any physicians and making sure that we know what is the cause for your breathlessness before exercise, before making the suggestion of whether to take more puffs before your exercise.
Okay, I'm afraid that we've come to the end of our webinar. Thank you all for joining us at this Clearing the Air on Asthma forum. We hope that you have picked up useful tips on what to look out for and to stay healthy in this new age. Before we end, we would like to hear your thoughts on today's session. Do click on the link in the chat box or scan the QR code that you can see now on the screen to complete a short survey. And we will see you at the next webinar forum. Stay healthy. Thank you.